Welcome to Advanced Airway Management for the EMT and AEMT. It's going to be a continuing education class for those of us practicing as EMTs and advanced EMTs. David Good will be your instructor today. Mainly it'll be focused on supraglottic airways, and we'll have a little short lecture followed by skills demonstration for refresher. Our goal: student will demonstrate understanding of the supraglottic airway devices and safely perform placement, confirmation, and ongoing management of supraglottic airways in the pre-hospital setting. Cognitive objectives: define the role and purpose of a supraglottic airway devices in airway management. Explain the indications, contraindications, and precautions associated with supraglottic airway placement. Discuss complications and troubleshooting techniques for compromised airway seals and displacement. Our psychomotor objectives are: select the appropriate supraglottic airway size based on patient assessment. Prepare our equipment, perform airway positioning, oxygenate the patient prior to placement. Insert the supraglottic airway device utilizing proper techniques specific to the selected device. Confirm airway placement by using bilateral chest rise, lung sounds, absence of epigastric sounds, and end-tidal CO2 monitoring. Secure the device to ensure stabilization during movement and transport. Ventilate the patient effectively with a BVM through the supraglottic airway while maintaining appropriate rate and volume. Our effective objectives are: exhibit professional behavior and teamwork during airway management scenarios. Be a patient advocate, prioritizing oxygenation, airway protection, and comfort. Comply with universal precautions and infection control standards during all airway procedures. Maintain composure during the high-stress airway management scenarios, demonstrating clear communication and effective clinical judgment. Why this matters. Airway is a life or death skill. Failures often happen due to hesitation or poor BVM technique. EMTs and AEMTs must act fast and stay within their scope of practice. The AEMT airway role, as well as the EMT role, is maintain and protect the airway, provide adequate ventilation, utilize supraglottic devices when needed, and request ALS intercept when indicated. For those of you who should be familiar, considering this is continuing education, just a quick overview of the airway anatomy. So, upper airway, lower airway, and mainly what we're going to be talking about for this section, right in here, exactly what supraglottic airway covers, as we'll show in the oncoming slides. Okay, our key anatomical considerations for this would be obesity with soft tissue collapse, facial trauma, poor OPA or NPA mask seals, limited neck mobility. It could come from just a patient having limited neck mobility, as well as C-spine precautions, C-collars, manual stabilization. Beards and dentures, they can make BVM seal difficult. Okay, for EMT and AEMT, airway is kind of a go, no-go for a decision. You're going to assess the breathing and airway patency. If it's maintainable, you support with BLS airway. So, your standard oxygenation, BVM, OPA, or NPA. If it's not maintainable, move immediately to a supraglottic airway. And always reassess ventilation after every step. So, as we know, paramedics have a whole algorithm they go through for airway. BLS providers and AEMTs, much more simple. Go, no go. Airway tools in the EMT and AEMT scope, at least here in Kentucky: OPA and NPA, back valve mask, supraglottic airways, suction and oxygen delivery systems. Okay, supraglottic airway review. Here in the photo we have an iGel or an LMA. As always, insert following your manufacturer guidelines and your training. So every department can be specific for what they carry. Whatever you have is what you need to go with, and local protocol. And as with all airway, confirm placement, chest rise, end-tidal if available, and auscultation, and reassess after any patient movement or any movement. So you load them in the truck, reassess. Unload them at the hospital, reassess. You move them from the house to the truck, reassess. as we were talking about earlier, diagram was showing what this, I think that's an IGL, but it's some form of LMA. It's just going to come and cover the tracheal opening and kind of block off the esophagus. So you're delivering breaths into the trachea while blocking off the esophagus. Same as the King, same as all the other blind insertion airway devices. I just prefer this one because of its ease of use. Case example. Our scenario: unresponsive trauma patient with poor mask seal, SpO2 of 84%. You've attempted bag valve mask with 2 rescuers. What is your next move? It's not working with just BVM. You start looking for an airway adjunct. Just going to move on to the supraglottic airway. Take that airway and get adequate ventilation. Common pitfalls: delaying airway escalation. Thinking, it's okay, we'll see how this goes, and you wait too long. Poor BVM technique, not getting your good EC seal on the face, or beard, dentures. Whole lot of problems you build there. Inadequate confirmation of placement, not auscultating lung sounds, the epigastric involvement, not checking for chest rise and fall, or using end tidal. Forgetting to reassess the patient after interventions. So not checking after the OPA, see if that's adequate, not checking after putting in the LMA or supraglottic airway to see that it's patent. Reassessing after you moved them. It may have been right while you're in the house, get to the truck, not correct. You need to continuously reassess airway. Key takeaways: airway management is dynamic. Constantly reassess. Use no-go, no-go decisions, not complex flow charts. Like we talked about, EMT, AEMT do not need to use the airway algorithm like paramedics. It's go, no-go. Know your tools and their limits. Know what your protocol is, know what you have on your truck, and know how to use them and when to use them. Never hesitate to call for ALS support. Starts getting out of hand. Paramedics have a lot more tools in their toolbox to handle airway. You can take care of the basics, but that patient might need to be intubated. They might still be conscious, and you can't take a conscious patient's airway. You can assist them, but you cannot take their airway. Always call for ALS assistance. Quiz time. What's the primary indication for a supraglottic airway device? Anybody? Of course, I'm teaching to an empty room, so patient without a gag reflex who needs airway protection. During your resuscitation, you insert a King airway and notice inadequate chest rise. Your first corrective action should be, anybody? And empty classroom. I don't know why I keep doing this. Reassess head positioning and reevaluate. A 45-year-old trauma patient has facial swelling and snoring respirations. Which airway management technique is most appropriate for AEMT or an EMT? That would be the entire purpose of the class, supraglottic airway device. All right, so for our skills portion of the training, we've got our airway mannequin, our appropriate PPE. As always, when you're dealing with airway, we have our suction, so portable suction canister, yonker, and suction tubing, bag valve mask, OPA, appropriate size for this patient. Just a quick refresher, measured from the corner of the mouth to the tip of the earlobe. We have our lubrication. We have our supraglottic airway, in this case an IGL, securing device for it, end tidal CO2, and just for demonstration purposes, a intact IGL as detailed, our one for training and what you'd actually get in the package. The package comes with the airway itself, lubrication, and the securing strap all in one container. And last but not least, oxygen supply. All right. This especially for skills, we need to make sure we have all our appropriate equipment ready, because you're gonna need it in the field. Train with it the correct way the first time, you get to make it a habit, you're not gonna miss something in the field. Okay, you are dispatched to an unconscious, not breathing male patient found unresponsive and apneic. Okay, your scene is safe. Proper PPE for BSI. So we've got our gloves on. First you check for responsiveness. You get no responsiveness. So you're going to assess airway, realize the patient is apneic. This is where you manually open the airway. I did not do so as the airway was open on this airway mannequin. This would be achieved by either a head tilt chin lift or a jaw thrust maneuver. So we're going to start with our bag valve mask, using proper technique for a good mask seal. And breathing 10 to 12 times a minute. You're going to check for gag reflex. We're going to try an OPA. As I'd shown earlier, it is the appropriate size. You're going to insert your OPA and continue with bag valve mask respirations. You will need to connect your bag valve mask to oxygen supply. Given that, we're going to simulate that due to an empty tank. At this portion of the skill, I noticed that even with just the airway adjunct, my SpO2 is not rising accordingly as we would desire, so I'm going to look for a further intervention. I would, if I had a partner, instruct them to continue ventilations while I prepare for the advanced airway. So since I don't have a partner, we're just going to pause that portion and I'll show you for my prep. Removing the airway adjunct. I go ahead and place my securing device so I'm not fumbling with it. I would remove my eye gel from its container. Put the lubrication on the tray, making sure that my eye gel does not touch anything. Apply lubrication to the distal tip. Make sure to not get any into the airway opening itself. Once the tip is lubricated, we pre-oxygenate the patient as your partner was continuing ventilations. So we're going to do the tongue jaw lift and insert the device. Going to apply pressure until you meet definitive resistance. Secure it in place. Because eye gels have this tendency to want to shoot back out because of their shape. 5 AEM. And continue ventilations at a rate of 10 to 12 breaths per minute. You will now assess the airway. You've done as we talked about in our PowerPoint. You've made a change. You've inserted an advanced airway device, so you would auscultate lung sounds. Auscultate, make sure you don't have any epigastric involvement. Make sure you have bilateral lung sounds and equal chest rise and fall. And if at all possible, use end-tidal CO2 for more confirmation. You can use end-tidal, you can use a colorimetric device. But anyway, always confirm your airway placement, and if at all possible, confirm it in multiple ways. Of course, everybody always goes for listening, but anything extra never hurts. And at this point, you will just maintain adequate rate and volume and assure through reassessing your patient that you keep an adequate patent airway. And once again, the rate should be between 10 to 12 breaths per minute and the appropriate tidal volume delivered to the BVM. You don't take the BVM, just squeeze it out of it, and nobody breathes that much. On adult size BVM, you're usually using about a third of it. Thank you for watching. Keep training, keep learning, and always protect that airway.